Hello, everybody. My name is Dr. David Savin. I'm going to talk about the shoulder, so new and innovative treatment strategies, kind of give you some basics, common injuries, current strategies for treating them, and what's up and coming and what's new. I have some disclosures. I'm a consultant for a couple shoulder companies or implant companies. So a little bit about me. I was born and raised in Los Angeles. I went to college and medical school at UCLA. Then I went to train for orthopedic surgery in Chicago at the University of Illinois. And then I did fellowship in Chicago as well, where I trained at Rush University. As part of my training, I was also one of the team physicians for the White Sox and the Chicago Bull as a fellow in Chicago. So the little bit of basics about the shoulder. It's a ball and socket joint. Imagine if it's similar to a golf ball and a golf tee, and the golf ball rotating on the golf tee. So it has the most motion of any joint in our body. And it does this by a combination of using ligaments and tendons to get those motions that we have. And they're all important for stability and function of the shoulder. When the ligaments aren't working correctly, or the bone is arthritic, or the muscles are not functioning correctly, you can lose function in the shoulder. So there's a lot of muscles in the shoulder. There's the big muscles and the small muscles. The small muscles are the rotator cuff muscles. These are the ones that give us the stability. They hold the shoulder joint together and make it so that the larger muscles are able to do the flexion, extension, the rotation, the lifting the arm above the side, and bringing the arm in a circular motion. So the big muscles are the deltoid, the trapezius, the latissimus dorsi, the pectoralis major, and the small muscles are the rotator cuff muscles. So how do you prevent shoulder injuries? Well, you have to maintain adequate strength and flexibility of all the shoulder muscles. You have to have good posture. One of the key things I always talk to my patients about during rehabilitation is getting the back and core strong, because you need a good core and strong back muscles to stabilize the scapula, which then allows the shoulder to perform the duties it has to do. Proper techniques with working out, proper warm-up, and good protective gear if necessary. So what type of injuries do we see? We see sprains, dislocations, overuse, and of course, fractures. So what is an AC joint separation? AC joint separation is when the connection of the clavicle to the scapula, which is the only floating bone in our body, gets the clavicle is the only connection of the shoulder girdle to the rest of the body, and the ligaments that hold that together, they tear or injure in some sort of way. This usually happens when falling directly on your side or onto your hand. It's commonly seen with bike accidents, skating accidents, one-wheel accidents, or falling off a horse. So the mechanism is, again, an impaction to the side of the shoulder. And as you can see on these images right here, if you compare the one on the right and the one on the left, the clavicle is raised upwards. Now, what do we see? We typically see some sort of deformity. This is at the distal end, and they say that the clavicle is raising up, but it's actually not the clavicle raising up, it's the rest of the shoulder falling down. And that's where we get the piano key sound, where we could lift the shoulder up and reduce the clavicle. And usually have some pain with motion and with palpation. Usual treatment of this is conservative. Most people do really well. In fact, I have my own AC separation and I did perfectly fine. Rarely do we need surgery for this. For the very unstable ones, we do require some sort of a reconstructive or ligamentous repair surgery. How about clavicle fractures? Similar mechanism, but instead of the ligaments getting injured, the bone actually can break. I usually have the rule of 2 wheels, racket sports, or 4 wheels or 4 legs. So these are commonly seen in mountain bikers, road bikers, people riding horses and falling off. Again, it's falling on the outstretched hand or directly onto the side of the shoulder. And the clavicle bone is typically pretty obvious when it breaks, especially when it's pretty displaced. The way we take care of this is it really depends on how the fracture is displaced. If it is an unstable and displaced fracture, we typically do use plate and screws to hold everything together, but the majority of clavicle fractures can be treated without surgery. So the recovery is going to be 1 month in a sling, protection for 2 or 3 months, and the goal is to restore motion and function. Some people get back a little bit faster. I believe Aaron Rodgers had a clavicle fracture that was fixed, and he got back to NFL football within 6 weeks. But I'm not sure if everybody can compare themselves to Aaron Rodgers. How about a shoulder dislocation or glenohumeral joint dislocation? This is when the actual shoulder falls out of the socket. This is the golf ball falling off the golf tee. This is anterior most commonly. It can be posterior, inferior, or multidirectional. And usually it's pretty obvious. You see a deformity of the shoulder. The shoulder won't move. Some people are able to do this on command by being hyper lax or very flexible. And we usually see this on X-ray. It's X-rays that we use to identify this dislocation. And you can see that the ball is no longer sitting in the socket. The way this happens, the arm's usually forced into rotation and lifted away from the body. And it usually requires a significant force because in order for this to happen, you tend to tear some sort of a ligament or rotator cuff in order for this damage, the shoulder to get out of the socket. And it's usually a posterior driving force of the humeral head to get it posteriorly. The signs and symptoms, we have deformity. You're unable to touch the opposite shoulder. You have pain. And in very rare circumstances, the arm can be locked in a certain position and you cannot move it. So how do we treat this? Well, first, we have to get the shoulder back in place. And this is commonly done by the emergency room. If this is not done in a timely fashion, it's very difficult to get it in once it scars in an abnormal position. Those sometimes require surgeries to reduce it and or reconstruct the shoulder to make it more stable. Immobilized for 1 to 2 weeks, we limit activity and strenuous activity for 4 to 6 weeks, and we do a physical therapy program focusing on getting your motion and strengthening back and making sure that the muscles that stabilize the shoulder are strong. After the first dislocation, there's a fairly high incidence of recurrence if you're younger than 20 years old. Unfortunately, the older we get without a recurrence, the less likelihood that would happen again. How to reduce it? Well, there's a lot of different ways, but it usually requires some sort of pulling to get that shoulder back in place. Usually what you see in movies when they hit the shoulder on the wall, that's not really a good trick to get this to reduce. It usually requires some good sedation and some traction to get the shoulder back. How about a biceps tendonitis and biceps rupture? So a biceps tendonitis is anterior shoulder pain, where a biceps rupture is where the tendon ruptures from the shoulder, causing this Popeye deformity on the image that you can see on the right side. So the biceps tendon is the only tendon that traverses or travels through the shoulder, and it goes through a connection between the rotator cuff muscles that creates a tunnel. This may spontaneously rupture, and commonly people have complaints of anterior shoulder pain when this is painful. When it spontaneously ruptures, a lot of times that pain can actually go away and you kind of self-treat yourself. So what do I do to treat biceps tendonitis? Well, we try some anti-inflammatory medications. We do a diagnostic injection. The injection should alleviate the pain almost immediately in the clinic. And we try rest and rehabilitation. And when this does not work, we do often do surgery for this. This is probably one of the more common surgeries that I do, as unfortunately, despite everything we do for conservative care, it does not always work. And you can see on this video, let me actually press play, that this biceps tendon is starting to shred as it's in the shoulder, and it can be very inflamed. So this tendon traveling the shoulder can cause a lot of pain as it's going through a tunnel, and its attachment site could also be fairly loose. So again, we actually cut that tendon out of the shoulder, and they usually reattach it near the armpit area. So the surgery, cutting the tendon out and reattaching it using some sort of an anchored device to hold it down to the bone. The recovery is going to be 1 month in a sling and 3 months for protection. It's highly successful of resolving this anterior shoulder pain. Also, could be the deep posterior shoulder pain. And I'll say that the biceps tendon involvement is very common with a rotator cuff tear. A lot of times with the recovery, I'm telling people to slow down. And even if somebody tells me they heal fast, tendons do not heal very fast to tendon, and they don't heal very fast to bone. It usually takes about 3 months until we have a decent amount of healing for us to start some light strengthening. How about AC joint arthrosis? Just like the separation of the AC joints, you could have arthritis of the AC joint, as this is a weight-bearing joint for the arm. So when you're doing push-ups, lifting away from your body, the AC joint gets loaded. And this is pain at the top of the shoulders, very common with weightlifters, and you can have significant difficulty with sleeping on the side of the shoulder. And the surgery is very simple. We just shave away the joint of the clavicle, so that way there's space between the two bones. This is not commonly an isolated procedure. This is more of an add-on procedure when we're doing other stuff in the shoulder, and this can be done all arthroscopically. The recovery, again, not an isolated procedure. The isolation, if it is isolated, you resume as tolerated on any activity that you want to do. If combined with other procedures, it really depends on what the rate limiting step or rate limiting procedure is, and that's going to be what determines what the recovery will be. How about the rotator cuff? It could be a strain or a tear. It's usually lateral shoulder pain. It really commonly presents with night pain. You can have a lot of weakness with this. And remember, the rotator cuff is the tendon that stabilizes the shoulder and gives us the fulcrum or the stability that we need for the big muscles to work. When you lose your ability to rotate, it's usually the rotator cuff that becomes torn. And this could be just pure tendonitis or a tear. What is the mechanism? It could be dynamic rotation of the arm at high velocity, such as overhead throwing, overhead lifting, poor scapular control when lifting, and it usually involves patients that have a history of impingement or instability. What are the signs? We see pain with muscle contraction, tenderness on the side of the shoulder, a lot of weakness, and we have specific tests that we can do to test each individual muscle of the shoulder to determine where the pain is coming from. The complete tears can produce pain and loss of function and swelling. You may even lose your ability to lift your arm up if the tear is significant enough. And it very commonly is seen when people commonly have pain when they're sleeping. So what about just impingement syndrome, where it's just bursitis? There's a second bone called the acromion, and when you lift your arm up, there could be compression of the supraspinatus against this bone, which can cause a lot of pain. We usually try to rehab this and maybe consider a cortisone injection to help alleviate that pain. And what we're doing is we're trying to reduce the inflammation of the shoulder and get those muscles stronger so they balance the shoulder out a little bit better. So what are our treatments? So rest, ice compression, elevation exercises, decrease the level of activity if you figure out what's causing this to happen. If you're playing tennis 7 days a week, that could cause the rotator cuff tendonitis. We exercise, try to really strengthen the shoulder. We do injections that are diagnostic and therapeutic. You really should leave the office with a significant reduction in pain. When I give my injections, there is a large component of the injection having some numbing medication. And if that numbing medication is in the right spot, the pain should go away. Even if there's a tear, the pain should go away. What about rotator cuff tears? Well, these are where the tendon gets detached to the bone. This could be degenerative or traumatic. It's often confirmed by MRI. And you can have persistent pain despite treatment, and again, pain with sleeping. Pain at night, trouble sleeping is one of the most common things that I see with rotator cuff and shoulder pathology. And one of the common things that causes to happen is you're distracted during the day and there's a lot of white noise that keeps you distracted from feeling the shoulder pain. And at night, everything shuts down and you're focusing on what's left, which is usually the shoulder pain. We usually get diagnostic MRIs to determine what we're looking at, and there's real difference between the quality of the MRI. It confirms the diagnosis, it confirms how or if I can repair it, and it also confirms other pathology. There are open MRIs, but these open MRIs typically are not as good quality as their lower magnet and their bigger space, and you just cannot see the image as well. And you can see between the left and the right when there's very significant difference in what we're looking at for the MRI. So I try to encourage everybody to get a regular MRI if possible. And if we're going for an open MRI, there's certain facilities that have a better open MRI than others. And I could direct you that way if that's the situation. What other imaging options do we have? Well, there's ultrasound, and the ultrasound can show us a dynamic muscle of the shoulder. And there's also needle arthroscopy, which I think is a little bit better for the knee, but it is a growing technology for us to be able to look with a camera to see what's going on in the shoulder. We've trialed this a little bit, and we're not really doing much in our office, but it is an option for us to look at in the surgical room. But it is something that the technology is getting better on, and it might be something that will be available for us to use in the office in a short period of time. So what about rotator cuff tears? Well, a rotator cuff tear is where the tendon is detached from the bone, and it can be a small one like the one on the left where there's a small hole for the tendon where it got lifted up from the bone, or it can be a very large one like the one on the right side where the tendon is retracted and pulled away and the humeral head is now bare. We can do this open or arthroscopic. Pretty much every single one of mine is done arthroscopic versus open. We have less of a risk of stiffness. We have better visualization, and I believe we can repair these better when these are done arthroscopic versus an open procedure. Arthroscopic is now considered standard of care when compared to open procedures. So this is an example of a rotator cuff tear. This video is not working, unfortunately, but there's a tear of the tendon, and the tendon is pulled away from the bone. And what I'm able to do is I'm able to pull the tendon and reattach it back down to the bone using sutures and anchors, so that we no longer see the hole where the tendon used to be. And this is another video where you can see a torn rotator cuff where the tendon is lifted away from the bone. And this is an example of how we repair it. We use sutures and anchors to compress the tendon down to the bone and get this tendon to heal. While this construct is very strong, it is not strong enough for you to do early activity, including strengthening, as we need this the tendon to heal down to the bone to give us the longevity and the long-term strength that we need. So what if the tendon is not repairable? What if we cannot fix this? What if it's a revision surgery? So our options are debridement, superior capsular reconstruction, balloon spacer, and the reverse total shoulder arthroplasty. And I'll go over each one of those. But sometimes these tendons are so torn that we have to have a backup option. This is an example of an MRI where we see the rotator cuff is retracted really far away from where it has to go. This one's over 4 centimeters away, and being able to pull that tendon under no tension is a very unlikely in this situation. So what about graft? Well, if we have a really big tear, we can put a graft to bridge the space of the bad tendon. And these work out pretty nicely where we repair the tendon, and you can see in the middle video where we actually already repaired the tendon. And then in the last video, what I do is I put a graft right on top of it and use that to kind of give us a little bit extra structural integrity. What about superior capsular reconstruction? This is another surgery that we have available to us where the entire rotator cuff is completely torn, and we use a very thick graft, which is cadaver tissue, to create a superior capsule or superior suspension bridge that holds the shoulder down. This surgery requires a long recovery, and it does have a good success rate, but it is more prone to failure than other procedures, given that this is a reconstructive surgery. And again, this is a video of us doing this surgery where at first there's absolutely no tendon available on the left side. On the right side, you can see that graft was incorporated into the top of the shoulder, all done arthroscopically. What about the balloon spacer? This is now FDA approved. I kept in this previous lecture years ago, I'd said this was be available, but now now is currently FDA approved. And the idea behind this balloon is it's going to create a spacer on the top of the shoulder that supports the shoulder, that gives us the ability for the big muscles to work a little bit better. Unfortunately, this technology is so new that no insurance company has been covering this. And so it's considered not experimental as FDA approved, but it's not available in the hospital yet unless it's paid for by cash until there's codes for the insurance to start approving this. It is new technology, and the results out of Europe and Israel are very fantastic. We don't have much experience with this here yet, as it's brand new and just recently approved. What about lower trapezius transfer? This is a newer technique that was recently done. It came out of the Mayo Clinic. And what we're doing is we're actually moving a muscle, which was your trapezius, one of the back muscles, and transferring it to the shoulder. This is a really nice and slick technique, and it works really well with people being able to restore function. This works better if the rest of the rotator cuff, including the subscapularis, is intact, and we're reconstructing the supraspinatus and infraspinatus tendons. And the goal is to be able to restore their motion and range and function of the shoulder after this is done. All these reconstructive surgeries do have a long recovery, as tendons take a long time to heal, and the recovery takes somewhere between 6 to 8 months. What about the reverse total shoulder arthroplasty? This surgery was designed for rotator cuff arthropathy, meaning that the rotator cuff is so bad that none of these options will work for you. Or you want a more predictable option that's not a reconstructive surgery that does have a failure rate higher than 10 to 20%. This is a pretty much sure shot for good shoulder function and good restoration of motion and good strength and pain relief. The complication rates are very low with this. The success rate's very high, and this is an easier recovery. Complication rates are much higher with this particular surgery if you're younger than 55 years old. So we tend to err on the older side for us to recommend this surgery and try to reconstruct the surgery for people that are much younger. What are my recommendations? Well, it really just depends on the person, not just the age. So we'd see what your goals are, what your function is. You can have a completely torn rotator cuff, but have good function and no pain, and I would not recommend any surgery for you. It really just depends on how you feel. So what's the right option? It depends. It depends on what your goals are, what your how willing you are to try to repair your shoulder. If I recommend a arthroscopic rotator repair, but I tell you there's a chance of failure, if I get this to work, you'll be better off in the long run if we can get the tendon to heal. But there's a chance that even if I do everything I can to repair the tendon, that it does not work. That's where we have the shoulder replacement, the reverse shoulder, which works really well in that setting. And sometimes people prefer to just go straight to the shoulder replacement, as it's a predictable option. It can be done as an outpatient. It's a shorter surgery and an easier recovery. What about shoulder arthritis? This is a different issue than rotator cuff issues. This is where the ball and socket are no longer coated with a smooth cartilage. So it's like driving on a gravel surface versus a smooth road. The humeral head no longer is round. It has osteophytes. It no longer has a smooth coating, but the rotator cuff is usually still okay. It could be from age, overuse, trauma, instability. It could be genetic. You usually have pain, loss of motion, especially rotation and going behind your back. You have difficulty with certain activities, and you can also have a lot of sleep pain. Fortunately for the shoulder, we don't walk on it, so we typically tolerate shoulder arthritis better than hip and knee arthritis. So what do? We could try non-steroidal anti-inflammatory medications, cortisone injections, viscoelastic supplementation like the gel shots. These are not FDA approved for the shoulder, and most insurances do not cover them because of that, but sometimes we are able to get it approved, and we have reasonable results with that. What about platelet-rich plasma and stem cells? There's some good studies in the hip and knee literature that suggest that that is better than the gel shots and the steroid shots, but insurance is not paying for those. So we have on the left side, the total shoulder arthroplasty. That's the shoulder replacement that's done for arthritis, and the reverse shoulder on the right side. These are different surgeries for different purposes, but sometimes if the glenoid is worn down, we'll prefer to use the reverse shoulder replacement depending on the clinical setting. So what to expect? Most patients are done as outpatients. You get improved pain and function. You wear a sling for 1 month. It takes about 3 months for tendons to heal. In order to do this surgery, I have to I have to release a tendon to get into the shoulder, and then I have to repair it. So we have to wait for that tendon to heal. And usually for golf or tennis, it's about 4.5 months from surgery before we are able to do that. How long will it last? Well, we're seeing 93 to 95% survival at 10 years. So we're seeing good longevity out of these implants. The majority of the complications, if they were to happen within the first 3 months. Our complication rate is very low as we have a high volume center. In fact, a couple of years ago, I think our hospital was ranked number 7 in the country for volume of the surgery. And with volume, you get experience. So our results have been very good. The dislocation rates are less than 1%. The infection rates are less than 1%. Overall, the results have been fantastic with the shoulder replacements. What other options? What's new with shoulder replacements? Well, we're now getting more technology that allow us to plan the surgery out a lot better. So we have preoperative planning software where we could virtually do the surgery and determine the correct implant that is suited for your shoulder. We also could have patient-specific guides. When normal guides won't work for your shoulder, we have these new guides that allow us to put the implants in the exact position that we planned it in. We also have augmentations where we're using plastic, the glenoid socket, or metal to fill in bone defects where we didn't have these implants before to fill these bone defects. And again, reverse shoulder replacements, these were not available before 2004, and now it's the most common shoulder replacement as the functions tend to be very predictable and they work really well in the right setting. There's also newer generation glenoid implants where they're pegged and finned. So these ideally have a better chance of having bone integrating into them, which could reduce the chance of failure. What if you have poor bone stock? What if the bone is soft? Or what if the bone is missing a lot of cartilage posteriorly or a lot of bone posteriorly? This is where the augments come in. This is where we are able to reconstruct using a non-symmetric implant that is thicker on one side than the other side to allow us to fill this bone void. And these work really nicely, and these ones are the type of surgeries that require some preoperative planning. We have a lot of different implant designs for different problems, and not every implant will work for each individual person, so we have different options available for each patient. What about preoperative planning? So this is that software I was telling you about where I'm able to virtually do a surgery ahead of time, where I'm able to see exactly how the implant is going to fit and make sure we have good contact of the bone and the implant is correct for the specific patient. And these work really nicely. What's next? Well, augmented reality. This is new software that is being developed and a new tech that's being developed that allow us to see this preoperative planning in real time. We're wearing some virtual goggles that allow us to implement this preoperative plan on the surgical field so we can see how well this will work. And this is something that is still really early in development, but it is being developed. We're also working on robotic shoulder replacements, where we're going to have robotic assisted glenoid and humeral head preparations. After surgery is done, what are the restrictions? Well, there's typically no specific restrictions given. Patients are able to resume activities between 4.5 to 6 months after surgery. You can get back to golf, tennis, gym, pickleball, snow sports, and more. I have a lot of weightlifters showing me doing pull-ups or push-ups after the shoulder replacement. Most people do fantastic with all these activities. What about shoulder fractures? Well, these are a very common injury, and we see a lot of them out here. These are considered fragility fractures, meaning they're typically a sign that your bone is not as strong as we would like it, and we should consider looking into getting the bone stronger with vitamin D or calcium or other medications. And typically, when you have one fragility fracture, you're more prone to having other ones. This could be from a low energy or mechanical fall, or a high energy motor vehicle accident or trauma. Majority of these can be treated conservatively, but and the older you are, the more displacement that we can tolerate and get to heal. Sometimes the fracture is so bad where the ball and socket are just no longer in the same zip code as the rest of the shoulder joint, and we have to do some sort of a reconstructive procedure. Smaller fractures are amenable to repair or conservative care. And what we do for conservative care or minimally displaced fracture, which is the majority of them, is we keep you in a sling for about a month. We start working on some general range of motion and function, and progressively we increase the goals, increase the motion that we're going to do, and the exercises that you do at home. Sometimes we do formal therapy, but most people are able to do this at home. We always encourage vitamin D and calcium, and most people can expect 70 to 90% of their function being back. What about surgery? Well, we can use plate and screws. We can use some other type of implant constructs, or if the fracture is really bad, we could do a reverse shoulder replacement for a fracture. Recovery, we work on early restoration of motion. Depending on the type of surgery that we do, we keep it in a sling for 2 to 4 weeks. We send you to therapy, or we have you do the exercises on your own, and the recovery usually takes about 3 to 6 months. What other recommendations do we have to improve your recovery after a procedure or a fracture? Follow the instructions. We give very detailed instructions of what to do after surgery, and it usually follows the same protocol. We start with very gentle stretching, and making sure your elbow, wrist, and hand maintain their motion. Swelling is normal, bruising is typical, and what we try to do is gently maintain your motion. And depending on the surgery that we do, after the first week, you diverge into different protocols depending on what we want to accomplish. But again, our main goal for the first couple months is to get your motion back without sacrificing or injuring the repair. You will have pain, and pain meds will not make you pain-free. Our goal is to make you comfortable. There's no pain medication will make all the pain go away. And we usually do nerve blocks with surgery, meaning that you won't have much feeling of your entire arm for the first 12 to 24 hours. And that once that nerve block wears off, you'll go from absolutely minimal or no pain to feeling some discomfort. And that's where we want to use the pain medications to help manage it. An ice machine, I usually tell my patients that it's worth its weight in gold. It's fantastic for shoulder surgery. Unfortunately, insurance does not cover this, as it only really helps you for the first week or two, and beyond that, there's not much of a difference. These are available on Amazon, Craigslist, or available in our office for sale as well. Don't forget your stool stoppers while you're on narcotics. And that is it for the shoulder. Any questions?
All right.